Welcome to the Rad-On Smart Review GI Cancer series. Today we're really diving into a topic that I think beautifully illustrates the power of radiation oncology, anal cancer.
It really does. It's one of those areas, one of the few solid tumors where our field just completely changed the game.
Yeah, moving away from, really radical surgery.
Mutilating surgery often.
Exactly, to a standard of care that's non-operative, preserves the organ, and it's all built on definitive chemoradiation.
It's a huge success story, not just clinically, but for patient quality of life too.
So our goal today is to kind of trace how we got here. We'll start with the basics, the anatomy, the staging, because
Yeah.
you really need that foundation.
Right, you can't understand the treatment without understanding the disease layout.
Then we'll get into the history, specifically the Nigro protocol, which was just revolutionary.
Completely changed everything. And then we'll unpack the big trials that really cemented our current approach, figuring out the best chemo, how long to give it.
It's a great example of how clinical research builds on itself step by step.
Absolutely. So maybe the best way to frame this is with a typical case. Let's picture someone you might see in clinic, say a 65-year-old woman.
Okay.
And she comes in, maybe she's had rectal bleeding kind of on and off for maybe 6 months. And she feels like there's a lump down there, a perianal mass sensation.
Pretty common symptoms, but things that can sometimes get missed or delayed.
Exactly. So her initial workup is just critical. And thankfully, it's fairly straightforward if you're thorough.
You need a good history, of course, but the physical exam is key.
Absolutely key. You must do a digital rectal exam, a DRE, and you've got to carefully feel the inguinal nodes, the groin nodes.
Why are those so critical right at the start?
Well, because a surprising number of these cancers are actually palpable on the DRE. And those inguinal nodes, that's a primary drainage site we'll talk more about. Miss those, and you might miss the diagnosis or definitely understage the patient.
Okay, so what are you feeling for on that DRE? Is it just a lump?
You're feeling for any hardness, induration, maybe some lumpiness, nodularity, or, a clear mass. You want to get a sense of its size, if it's fixed or mobile, how much of the circumference it takes up.
And rule out other things too, presumably, like hemorrhoids.
Exactly. Differentiate it from benign stuff.
Yeah.
But ultimately, you need tissue. So endoscopy, looking inside with a scope and biopsy are absolutely required. No guessing.
Right. Get that path confirmation.
And once you have that confirmation, usually squamous cell carcinoma, that's like 80% of them, then you move to systemic staging.
Okay, looking for spread.
Right. Usually a CT scan, computed tomography of the chest, abdomen, and pelvis. Standard stuff, looking for nodes, liver mets, lung mets.
No, what about PT scans? I feel like we use those a lot here.
Yeah, good point. A PET CT is often considered, and it's not just optional. It can actually change the nodal staging in maybe up to 30% of cases.
Wow, so it finds things the regular CT misses.
It can, yeah. It picks up metabolically active areas that might be small nodes missed on CT, so it gives you a more accurate picture, which definitely affects treatment planning.
And one more thing for the workup.
Yes, the HPV link, human papillomavirus. It's strongly linked to anal cancer. So a comprehensive gynecologic exam is mandatory for women. You have to check for other HPV-related cancers like cervical or vulvar cancer. They can coexist, unfortunately.
Got it. Okay, so let's go back to our patient. We did the workup, the DRE and endoscopy show, let's say, a 3-centimeter ulcerated mass in the anal canal.
Okay, 3 centimeters. That size immediately brings us to a really critical anatomical landmark, the dentate line.
The dentate line. Okay, I remember this being important. It's inside the anal canal.
Exactly. It's about 2 centimeters up from the anal verge, the outside opening.
Uh-huh.
It's sometimes called the pectinate line. And it's not just a line. It's like a lymphatic watershed.
A watershed. Explain that. Like a dividing line for drainage.
Precisely. Think of it like the Continental Divide, but for lymph fluid. Where things drain depends entirely on whether the tumor is above or below this line. It's based on embryology, actually.
Okay, so drainage above is different from drainage below.
Totally different. And remembering, this is non-negotiable for planning radiation fields.
Is there an easy way to remember the patterns?
There is. We have a couple of mnemonics. For tumors above the dentate line, think ADIPI.
ADIPI. Okay, what's that stand for?
Above dentate, internal iliac, perirectal iliac. These drain up and inward, kind of like rectal cancer does, into the pelvis.
Up and inward. Got it. ADIPI.
Now, for tumors at or below the dentate line, think BDSIF.
BDSIF. All right.
Below dentate, superficial inguinal femoral. These drain outward to the groin nodes, the superficial inguinal and femoral nodes, like a skin cancer might.
Outward to the groin, BDSIF. Okay, that makes sense. So how does this directly impact what we do?
It directly impacts our radiation fields. It's the reason why, for almost all anal cancers, you must include the groin nodes, those superficial inguinal and femoral nodes, in your treatment field.
Even if the tumor seems higher up.
Even if it seems mostly above, if it involves the dentate line or extends below it, those outward drainage pathways are at risk. If you miss the groin, you could be missing sites of potential spread. It's a fundamental part of the treatment plan.
Okay, that's a really key point. Groin coverage is almost always needed because of that dentate line watershed.
Exactly.
All right, so we understand the anatomy, the drainage. Let's talk staging. How do we classify the extent of the disease?
We use the AJCC System American Joint Committee on Cancer, 8th edition. But here's the unique thing about anal cancer staging.
It's different from rectal cancer, right? I remember you saying that.
Very different. The key difference is that anal cancer T staging is based primarily on tumor size, not how deep it invades the wall like in colorectal cancer.
Okay, so how does that work?
It's pretty straightforward, actually.
Tumors 2 centimeters or smaller.
Tumors bigger than 2 centimeters, up to 5
The
centimeters.
tumor's bigger than 5 centimeters.
Yeah.
And T4. That's when the tumor invades adjacent organs, bladder, vagina, bone, etc.
So size is the main driver for the T stage. 2 centimeters and 5 centimeters are the key cutoffs.
Those are the magic numbers, yes. 2 and 5.
Okay, so back to our patient with the 3-centimeter tumor.
Right, 3 centimeters. That puts her squarely in the T2 category.
T2. And we said her initial scans didn't show any suspicious nodes?
Correct. Let's assume no suspicious nodes on imaging, so N0.
So she is clinical T2, N0. What stage does that make her overall?
That makes her stage 2A in the AJCC 8th edition system, clinical T2 N0 stage 2A. And that staging is what really guides our next steps.
Okay, before we jump into those next steps, maybe let's take a quick step back. To really appreciate why our current treatment is such a big deal, what was the treatment before all this? Say back in the 1960s or early 70s for this T2-ender patient.
Yeah, that's crucial context. Before the work we're about to discuss, the standard of care for her would have been surgery. And not just any surgery.
The APR.
The APR abdominoperineal resection. For decades, that was really the only potentially curative option.
And remind us what that involves. It's pretty major.
It's incredibly major. You're removing the anus, the rectum, part of the sigmoid colon, and the unavoidable consequence is a permanent colostomy.
A permanent bag for life.
Exactly. A huge physical alteration, significant psychological impact, issues with body image, sexual function. It was life-changing, and not in a good way, even if it cured the cancer.
So the drive to find something less invasive, but just as effective, must have been immense.
Desperate is probably the right word. A real need for a better way.
And that better way really started with one person, didn't it?
It really did. Dr. Norman Nigro at Wayne State University. His work in the early 70s, published in 1974, completely changed the paradigm.
Oh.
It was gutsy.
What was his idea? What did he hypothesize?
He looked at anal cancer, mostly squamous cell carcinoma, and thought, well, other squamous cancers, like head and neck or cervix, are pretty sensitive to radiation. Maybe anal cancer is too.
Okay, makes sense.
And he thought, what if we combine radiation with chemotherapy? Maybe we could shrink the tumor before surgery, make the surgery easier, or maybe even avoid it altogether. So he set up a protocol using a neoadjuvant approach treatment before the planned surgery.
Which was pretty novel for solid tumors back then, right?
Very novel, especially combining chemo and radiation up front. His regimen involved radiation, but a fairly modest dose by today's standards, 30 gray in 15 fractions.
30 gray.
Covered the tumor and the pelvic nodes, but the kicker was a chemotherapy combination he chose.
The famous combo.
The iconic combo, mitomycin-C and 5-fluorouracil. 5-FU?
Mitomycin and 5-FU. How are they given?
The mitomycin-C was just a single shot, a bolus on day 1, and the 5-FU was a continuous infusion over 4 days.
Okay, so mitomycin, 5-FU, and radiation.
Right. And we have a mnemonic for that to lock it in. Nigro's MFC.
MFC, mitomycin, 5-FU, chemoradiation. Got it.
So the plan, the original intent, was still to take these patients to surgery to do the APR after this neoadjuvant treatment.
Right, shrink it down first.
Exactly. But then came the surprise. when the first few patients actually went to the operating room for their planned APR.
What happened?
Dr. Nigro looked at the surgical specimens, the tissue they removed, and in 5 of his first 6 patients, there was no cancer left.
Wow. Complete pathologic response.
Complete pathologic response, or PCR. The chemoradiation alone had seemingly wiped out the tumor completely. Imagine being in that OR.
That must have been stunning. Completely unexpected.
Totally unexpected. And it was that single discovery, that observation, that just flipped the script entirely.
It showed that maybe surgery wasn't necessary at all for cure.
Exactly. It established definitive chemoradiation based on his regimen as the new standard of care. Organ preservation was suddenly possible, and it became the goal. It was a massive turning point.
A true paradigm shift based on just a handful of patients initially. Incredible.
Incredible. But, while Nigro's work was groundbreaking, that initial series was small. To really make this the standard everywhere, you need larger randomized trials. Level 1 evidence.
Right, you need to prove it rigorously.
Yeah.
So what was the first big question the trials needed to answer?
The first, most basic question was, does adding the chemotherapy to radiation actually do anything significantly better than radiation alone? Was Nigro's chemo part really necessary?
Okay, so radiation versus chemo plus radiation.
Exactly. And the UKCCR Act 1 trial tackled this head-on. They randomized patients. RT alone versus RT plus the Nigro chemo regimen 5-FU and mitomycin C.
And what did ACTI show?
It was pretty definitive. Adding the chemotherapy dramatically improved local control, keeping the cancer from coming back in the treated area. The 3-year rate jumped from about 41% with RT alone to 66% with chemoradiation.
Wow, that's a big difference.
Huge. And it also significantly reduced the need for a colostomy down the line. So it clearly showed chemo was a vital part of the equation.
Okay, so ACTDI proved chemo helps. Was there other supporting evidence?
Yes, especially for patients with more advanced disease. The IRTC 22861 trial looked specifically at T3 or T4 tumors or node-positive patients.
Bigger tumors or involved nodes.
Right. And they also compared RT alone versus chemo-RT, and the results were, again, striking. The 5-year colostomy-free survival, meaning alive and without a bag, almost doubled.
Doubled? From what to what?
It went from about 40% with radiation alone to around 72% with added chemotherapy.
72%, that's massive.
Massive. It cemented the fact that chemotherapy wasn't just optional, it was essential for maximizing cure and organ preservation, especially in locally advanced cases.
Okay, so the trials firmly established chemoradiation is better than radiation alone.
No question.
So the next logical question then becomes, is the Nigro chemotherapy regimen, the mitomycin C and 5-FU, is that the best combination?
Exactly. Mitomycin C, while effective, has some pretty significant toxicities, right? Bone marrow suppression is a big one. It can really drop blood counts. And there's a risk, albeit small, of long-term lung damage.
Right, so people wondered if there was a less toxic alternative that worked just as well.
Precisely. And the main contender was cisplatin. It's another potent chemotherapy agent, works differently than mitomycin, and it's widely used in other squamous cell cancers like head and neck. Maybe it could be swapped in.
Okay, so mitomycin versus cisplatin, both given with 5-FU and radiation.
Right. And this led to 2 really important, large, pivotal trials that initially seemed to give conflicting answers, which caused a bit of confusion for a while.
The classic confusing trial results scenario. Okay, which trials were they?
The first was a big U.S. trial, RTOG 9811, Radiation Therapy Oncology Group 9811.
RTOG 9811.
Yeah.
Got it. What did it compare?
It compared the standard arm 5-FU and mitomycin C, given concurrently with radiation, against an experimental arm using 5-FU and cisplatin. But, importantly, the cisplatin arm also got 2 cycles of induction chemotherapy before the chemoradiation started.
Induction chemo first, then concurrent chemo-T with cisplatin.
Okay, and the results?
The results clearly favored the mitomycin C arm. Overall survival at 5 years was better, 78% versus 71%. And crucially, the colostomy rate was almost cut in half with mitomycin C, about 10% versus 19% in the cisplatin arm.
Okay, so RTOG 9811 says mitomycin C is superior to that specific cisplatin regimen.
Pretty clearly, yes. But then came the second big trial, this one from the UK, called ACT2.
ACT2. Okay, what did that one compare?
ACT2 also compared 5-FU mitomycin C versus 5-FU cisplatin, given concurrently with radiation. But the key difference, no induction chemotherapy in either arm. It was a straight comparison of the concurrent regimens.
Ah, no induction phase, just head-to-head concurrent treatment. And what did ACT2 find? ACT2 found no significant difference between the 2 regimens. Progression-free survival was basically the same, around 74% in both groups. Overall survival, colostomy-free survival, no statistically significant difference.
Okay, so 9811 says mitomycin is better, but ACT2 says they're equivalent. How do we make sense of that? They seem contradictory.
Exactly. And this is where you really have to put on your critical thinking cap and look closely at the trial design. It's not just about the drugs, it's about how they were given.
So what's the prevailing theory for the different results?
The leading hypothesis, and the one that's generally accepted, focuses entirely on that induction chemotherapy used in the cisplatin arm of RTG-9811.
The 2 cycles before the main treatment started.
Right. That induction phase pushed back the start of the definitive chemoradiation. It prolonged the overall treatment time for those patients in the cisplatin arm.
And why is that bad? Prolonging the treatment time.
Because we think it allowed time for the tumor cells to repopulate. Squamous cell cancers, like anal cancer, can grow back pretty quickly if you give them a break or delay the main punch. That delay, caused by the induction chemo in 9A11, likely undermined the effectiveness of the subsequent cisplatin chemoradiation.
Ah, so the cisplatin itself might have been fine, but the schedule used in 9811 made it look worse because of that built-in delay.
That's the thinking. The delay compromised the outcome. ACT2, without that induction delay, showed cisplatin was likely just as good as mitomycin C when given concurrently.
Okay, that makes sense. So where does that leave us? Which regimen is the standard now?
Well, because mitomycin C was clearly superior in one major trial, RTOG 9811, and proven non-inferior or equivalent in the other ACT2, the combination of 5-FU and mitomycin C remains the undisputed standard of care.
Got it. 5-FU and mitomycin C is still the go-to regimen, and the story of those 2 trials is a great lesson in looking carefully at trial methodology, not just the final conclusion.
Absolutely critical lesson.
Okay, let's shift gears slightly and distill some really practical take-home messages from all this evidence, some clinical pearls for residents.
Yeah, let's do that. Pearl number 1, building off that ACT2 trial. There is absolutely no role for maintenance chemotherapy after you finish the primary chemoradiation.
So once the chemo T is done, you're done with chemo. No extra cycles for good measure.
None. ACT2 specifically tested adding more 5-FU cisplatin cycles after the main treatment, and it showed zero benefit, just added toxicity. So don't do it.
Okay, no maintenance chemo. Got it. What's next?
Pearl number 2, and this one is huge GE, probably one of the most critical things to remember. Avoid treatment breaks during chemoradiation at all costs.
Avoid breaks. Why is that so important here?
Remember our discussion about tumor repopulation with the RTOG 9811 trial?
Yeah, the delay potentially hurting the cisplatin arm.
Exactly. Well, another trial, RTOG 9208, looked directly at the impact of a planned treatment break during chemoradiation. They deliberately built in a 2-week gap mid-treatment in one arm.
Okay, a planned 2-week break. What happened?
The results were, frankly, disastrous. The rate of needing a colostomy within 2 years shot up dramatically in the group that had the planned break.
How dramatically?
It went from about 7% needing a colostomy in the continuous treatment arm to 30% in the arm with the planned break.
30%? Just from a 2-week planned break?
Yep. It's a stark reminder of how aggressive these tumors can be if you let up on the pressure. You can think of it like running a marathon.
Okay.
If you decide to take a long, unscheduled nap halfway through, your chances of finishing well, or maybe finishing at all, plummet, right?
Right. You lose all momentum.
Same idea here. Treatment continuity is absolutely key. You have to keep the pressure on the tumor cells, avoid breaks unless absolutely medically necessary for managing acute toxicity, and even then, keep them as short as possible.
Wow. Okay. Avoid breaks. That's a really powerful message from that trial. Any other major pearls?
I'd add a third one. Vigilant long-term follow-up is crucial. Even with high cure rates, recurrences can happen, especially in the first few years.
So regular checkups, DREs.
Absolutely. Regular exams, including DREs, every 3 to 6 months initially. You're looking for any subtle changes, any signs of local recurrence. Sometimes you can feel something before it shows up on a scan. Early detection of recurrence might allow for salvage treatment, often surgery, but the goal is cure the first time around.
Okay, so no maintenance chemo, avoid breaks like the plague, and follow up closely.
Got it. Those are 3 big ones.
So let's tie this all together and go back to our original patient. 65-year-old woman, 3-centimeter tumor, no nodes, clinical T2 and Nigro, stage IIA, squamous cell carcinoma of the anal canal. Based on everything we've discussed, what's the plan for her?
The plan is clear and evidence-based. For any squamous cell carcinoma of the anal canal that's T2 or higher or node positive, the standard of care is definitive chemoradiation, using the 5-FU and mitomycin C regimen based on the Nigro protocol and validated by ACT1, EORTC 22861, RTOG 9811, and ACT2.
And the goal is?
The goal is cure with organ preservation, to achieve a complete response to the chemoradiation and completely avoid the need for that radical APR surgery.
It really is a standard designed around maintaining quality of life while still being highly effective.
Exactly. It's one of the best examples of that in oncology.
Now, we've focused a lot on the what and why, the evidence, the chemo regimens, but the how, the radiation delivery itself, is obviously critical too.
Absolutely vital. And as we talked about with the anatomy, that dentate line and the lymphatic drainage mean our radiation fields almost always have to cover the groin nodes.
Right, the BDSIF drainage pathway.
Precisely. So meticulous treatment planning is key. Modern techniques like IMRT intensity modulated radiation therapy allow us to be much more precise than in the past.
What does that precision allow us to do?
It allows us to deliver the necessary dose, maybe 50.4 gray or higher, depending on the stage. We'll get more into doses in part 2 to the tumor and the lymph node areas at risk.
Including the primary tumor GTV,
Yeah.
the microscopic spread CTV, and those nodal basins like the perirectal, internal iliac, and inguinal femoral groups.
Exactly. While minimizing the dose to the surrounding healthy organs, the OARs, or organs at risk.
Which, in this area, would be things like the small bowel, the bladder, the femoral heads, the genitalia.
All of those. By carefully shaping the dose, we aim to maximize the chance of killing the cancer while minimizing side effects, both acute ones like skin reactions or diarrhea, and long-term ones like bowel dysfunction or bone problems. It's all about optimizing that therapeutic ratio.
Great. Okay, I think we've covered the foundations really well. Ready for a quick board blitz to test some of this?
Let's do it, and me.
All right, case 1. Which is the appropriate treatment for a clinical T2N0 squamous cell carcinoma of the anal canal? A, wide local excision. B, definitive chemo-RT with 5-FU and mitomycin CC, neoadjuvant chemo-RT, followed by abdominoperineal resection. B, induction 5-FU and cisplatin, followed by definitive chemo-RT.
Okay, T2 and 0, that's definitely not surgery alone. Neoadjuvant, followed by APRC, is the old way we're trying to avoid. Induction cisplatin D was shown to be inferior in 9A11 due to the delay, so it has to be B. Definitive chemoradiation with 5-FU and mitomycin C.
B is correct. Standard of care for T2 or higher. Okay, case 2. In the IORTC 2286, one trial comparing RT alone versus chemo-RT for locally advanced anal cancer, what was the approximate 5-year colostomy-free survival in the chemo-RT arm? A, 40%, B, 50%, C, 60%, D, 70%.
The EORTC trial for advanced disease. Chemo made a huge difference in colostomy-free survival. It went from 40% with RT alone up to around 70%, maybe slightly higher, so D, 70%.
D is correct. It was 72%, nearly double the RT alone arm. Massive benefit. All right, last one. Case 3. What was a major difference in the design of RTOG 9811 and Act 2 that likely explains their conflicting results on the comparison of mitomycin C and cisplatin? ARTOG 9811 used a higher radiation dose. B. The cisplatin arm of RTOG 9811 included 2 cycles of induction chemotherapy, prolonging the overall treatment time. C. Act 2 did not include node-positive patients. The RTOG 9811 used bolus 5-FU, while Act 2 used continuous infusion 5-FU.
Okay, the conflicting results between 9811 and ACT2 regarding mitomycin versus cisplatin. The key difference, the one we think explains it, was that induction chemo in 9811's cisplatin arm. That prolonged the treatment time. So that's answer B.
B is correct. The induction chemo delay is the leading hypothesis for the difference in outcomes. Nicely done.
Good review questions.
So let's quickly recap the main takeaways from today's deep dive on the foundations of anal cancer treatment. First, remember staging. It's primarily by tumor size, not depth. T2 is 2-5 centimeters, T3 is 5 centimeters.
And remember that crucial landmark, the dentate line. It's the lymphatic watershed. Above drains up and in, ADIPI. Below drains out to the groin, BDSIS, which means groin coverage in radiation fields is almost always essential.
The treatment itself, revolutionized by Nigro. Definitive chemoradiation is the undisputed organ-preserving standard for T2 or higher disease.
And the chemo regimen of choice remains 5-FU and mitomycin C based on multiple large trials.
Oh, finally, those critical clinical pearls. No role for maintenance chemotherapy.
And perhaps most importantly, avoid treatment breaks during chemoradiation at all costs to prevent tumor repopulation and maximize success.
It's really an amazing story, isn't it? Going from mandatory radical surgery with a permanent colostomy to a highly effective organ-sparing treatment based on chemoradiation. Just shows the incredible progress radiation oncology has made.
It really does. A testament to careful clinical observation, rigorous trials, and always striving for better, less morbid treatments for our patients. And if you want to review these concepts further, you can find show notes and practice oral boards covering this and other topics at radoncsmartlearn.com. That's radoncsmartlearn.com.
Make sure you subscribe to Radonc Smart Review so you don't miss our next deep dive, Anal Cancer Part 2. We'll get much more into the technical details of radiation planning and delivery doses, volumes, constraints, all that good stuff. Thanks for tuning in.